Well, thank you again for the opportunity to speak to you. And it's been a great session. I have a little bit of a debate now, and we're going to talk about one-to-one transfusion ratio, and I'm giving the pro side, and then the esteemed Dr. Scalia, our friend, is going to give the con side. We'll run through a lot of data. What I want to do first is present a case, just to sort of lay the groundwork. So on Christmas Eve, a couple years ago, an 18-year-old male came in, shot in the right buttock. He had a pressure of 70, a heart rate of 138. Promptly went to the operating room. The X's show his two injuries. He had basically a transection of his right common iliac vein under the inguinal ligament, and then transection of his right hypogastric artery deep in the pelvis, which we controlled with 3-O-proline. In resuscitation, he received 23 units of red cells, 16 of FFP, 15 platelet packs, and a unit of cryo, and then damage control. And what this case demonstrates, I think, is what our current understanding of resuscitation is in the massively bleeding patient, with aggressive resuscitation minimizing crystalloid. We talked about that this morning. And then red cells, FFP, and platelets in a 1-to-1-to-1 ratio. And it makes sense that we do this because the patient is losing whole blood, and what we should give back is exactly what the patient has lost. The old standard of giving 3 or 4 or 5 units of red cells before we hung platelets or FFP, it's not a surprise that we finally recognize the coagulopathy as a major problem. What we want to prevent our patients from doing is going into this bloody, vicious cycle of acidosis, hypothermia, coagulopathy, where once that begins, it's very, very difficult to break. And the idea is to avoid that if we can. Now, we know that the coagulopathy that we see in our patients is induced by hypothermia, by the dilution of the fluids that we give, and as Dr. Rizzoli presented nicely and others have talked about, this trauma-induced coagulopathy that occurs from the instant of the insult. And this is really a new concept and has changed how we think and how we approach these patients. So the treatment in the massively bleeding patient is first, stop the bleeding, surgical control, avoid hypothermia, and then the one-to-one-to-one transfusion, if you will, hemostatic resuscitation. This shows the importance of stopping the bleeding, and what you see in both military and civilian data, that by the time you're hanging the 10th unit of blood on your patient, which is how we define massive transfusion, that 25% of the patients die. So irrespective of the injuries, once you hit that 10th unit, 25% of the patients die. By the time you hang the 20th unit, again, civilian and military data, half the patients will die. So when you're in the operating room, there should not only be the temporal clock, but that mental clock. When you're hanging the 10th unit, you want to do everything you can to stop the bleeding. Otherwise, you'll be more likely to lose the patient than save the patient if you can't stop the hemorrhage and fix the coagulopathy. And there were really a couple papers that really brought this to the forefront, and we owe our military colleagues a lot to bringing this to our attention. This is a paper from the Journal of Trauma in 2008, where they studied 391 soldiers, 92% penetrating injury, so young, healthy patients except for their acute injuries. They looked at ISS and mortality as their outcome criteria. And what they documented, which Dr. Rizzoli mentioned, is that 38% of the patients had measurable abnormalities in coagulation when they hit the front door. So it is the result of the injury. And as you see here, mortality, if the patient's INR was less than 1.5, normal was very low. If the INR were mildly prolonged, 1.5 to 2, then 10% mortality. And if the INR were greater than 2, then 50% of the patients die. This data is even more interesting when you look at it based on injury severity score, where you see ISS less than 15, 15 to 24, and then greater than 25, with normal INR in the green and then abnormal INR in the purple, and dramatic increase in mortality within each group of ISS when the patient is coagulopathic. So the coagulopathy is an independent predictor of mortality, just like the ISS is in these patients. This is a paper that I think really brought it to the forefront as far as a one-to-one transfusion by Borgman and Holcomb and his group, Journal of Trauma in 2007. 246 soldiers with greater than 10 units transfused in the first 24 hours. The average ISS was 18, and then there were 3 groups based on the proportion of fresh frozen plasma to packed cells. There was a low ratio group with 1 FFP to 8 units of packed cells transfused. The medium ratio group, which was 1 FFP to 2.5 packed red cells, and then the high ratio group, which approximated 1 FFP to 1 unit of red cells. And the difference in mortality was significant and striking. You see the low ratio group, 1 FFP to 8 red cells, 65% mortality. And for the median group, 34%, and then the one-to-one group, 19% mortality. And obviously, this caught everybody's attention because the differences in mortality are just so dramatic with an ISS that's 18 in all 3 groups. So the injury severity score is comparable in the 3 groups. This is civilian data from the GLUE grant, and it looked at basically the FFP to red cell ratio in a civilian population. 405 patients received 8 units of red cells in 12 hours, and then we used a cutoff of 1.5 FFP to red cells as a high group and then a low ratio group. And what we found is that there was a 52% lower mortality when we gave more fresh frozen plasma, and interestingly, the patients who received more FFP required less blood and transfusion, presumably because we stopped the bleeding faster by fixing the coagulopathy. So 16 units of red cells versus 22 units of red cells in 24 hours. And also in this study, the incidence of ARDS was half in the group that received aggressive FFP transfusion. You see this graphically on this slide, so it is an immediate event, and this survivorship advantage persisted over the month post-injury. Another way to look at the same data with a hazard ratio for mortality, again, it shows with a one-to-one transfusion, you cut the mortality by half. So dramatic difference in mortality in both military and civilian patients. This is another study. This is from LA County, 25,000 trauma patients admitted over 6 years. Of the patients who received transfusion, 11% received massive transfusion. That's 484 patients. And what they documented was the mortality rate decreased significantly with more FFP infusion. And again, similar to the Borgman data, you see with the low ratio group, now it's actually a 90% mortality, and then decreased to 25% with 1-to-1 or 1-to-2. And there are a couple studies that suggest not a great difference between 1-to-1 and 1-to-2 transfusion, as Dr. Moore has already mentioned. John Holcomb's study, published in the Annals of Surgery, looked at 16 level 1 trauma centers. This is actually 2008, 466 patients, an ISS of 33 for, so very severely injured, greater than 10 units of blood in 24 hours. And with the higher FFP to red cell ratio, there's a higher 30-day survivorship, and interestingly, the same for a higher platelet to red cell ratio. So one of the first papers to talk about the importance of not only FFP, but platelet transfusion in treating these patients. And what you see here is 4 groups. And there's a group that received high ratio of FFP and high platelet, high FFP, low platelet, low FFP, high platelet, and then low transfusion ratios in both groups. And what you see, the high FFP, high platelet group had the highest survivorship, The lowest was in the group that had low FFP and low platelets, and then the groups in between. So I think the important conclusion from this study is it's critical to transfuse the FFP as well as the platelets in a 1-to-1 ratio. Another study from John Holcomb that looked at the same thing, and again shows that giving FFP and platelets in that high ratio is a sustainable difference in survivorship over 30 days. This is a paper that Juan published in 2009 from New Orleans. 435 patients studied over 7 years, and this is 10 units in the operating room. So this is a group that is bleeding very rapidly, not 24 hours, but now in the operating room, an average OR time of about 2 hours. And again, compared 1-to-1 to 1-to-4 transfusion, and in the 1-to-1 group FFP, the red cells, 28% mortality versus almost double that in the high ratio group. So all of these studies have come up with the same conclusions and very, very similar curves as far as the importance of 1-to-1 transfusion. Some authors have suggested, and I'm sure Dr. Scalia will talk about this being a survival bias, the fact that the patients who die quickly don't have time to get more FFP and more platelets. We've actually looked at that in our data in a paper that's accepted but not published, that actually it's not simply a time phenomenon, that it is truly the effect of 1-to-1 transfusion. So I think in summary, damage control resuscitation, massive transfusions should include hypotensive resuscitation, early control of bleeding, use less crystalloid, and again 1-to-1 transfusion with platelets and FFP. Thank you very much. Muchas gracias.